Good afternoon and welcome to this webinar on understanding the benefits of automated repositioning, kindly sponsored by Frontier. My name is Jackie Fletcher. I'm going to be your chair for today. We have 3 separate videos for you to see and we're going to play them all back to back. Your speakers will be, first of all, Frances Kent, who is the Clinical Nurse Specialist Lead for the Community Equipment Service in Buckinghamshire Healthcare, and she's going to talk to us about the importance of repositioning. We'll also have Lisa Martin and Simon Bosley from Frontier, who will explain to us in a little bit more detail. If you have any questions, please feel free to pop them in the chat and we will take all your questions at the end. In the meantime, if you want to introduce yourselves to each other, that's really helpful so that we know who's online. And whilst you're doing that, can I introduce the first video, which, as I said, will be Frances talking to us about the importance of patient repositioning.
Hello, everyone. My name's Frances Kent. I'm the Clinical Nurse Specialist Lead for the Complex Needs for Equipment in Buckinghamshire. I'm the lead for the Community Equipment Service. And today I have got 10 minutes giving you an overview of a vast subject with regards to repositioning and turning our patients. So, where did the 2-hour turning regime come into existence? Well, we do have to go back to Florence Nightingale, who at least did start turning her patients. And then 100 years later, the famous neurologist Dr. Ludwig Guttmann, who started the spinal unit at Stoke Mandeville, also decided that every 2 hours was going to be the best for his spinally injured clients. But we now have official guidance. We have the EPUAP, the European Pressure Ulcer Advisory Panel, who does give us a lot of help making those decisions about what is best for our patients. There are about 18 points, and I'm not going to read them all out, but you can see that we have got very clear guidance and help to make decisions. But we also have NICE in this country, and NICE works with the NHS and government bodies to come up with the guidance to assist us in making decisions for patients. You can see where I've highlighted at the bottom that there is actually limited evidence on the most efficient position and frequency of repositioning for all age groups. There are a lot of studies and there are studies still going on, but they are still unclear whether prevention is because of the support surface or the actual repositioning. So we keep going back to the research, but at the moment, what we have to do is always make an individual risk assessment for our clients, and that goes for anything that we're going to do to help them. So with that individual risk assessment, we have to look at the diagnosis versus manual handling and versus safety issues. And given all the different diagnoses and their issues for those particular people, and the way that some of those diagnoses and neurological conditions do develop, the need for that repositioning and turning can change over time. And that's what we have to get going back to, is reviewing what we're doing for each and every one of the people that we're looking after. Now, when it comes to making that assessment, there are so many issues that we have to take into account. And we have to make an informed decision. And there are lots and lots of different parts that come into that to make that bigger picture and to help us make that informed choice that's going to be best for the person at the end of the day. And it might be that we need to involve other clinicians and other people to help us come to that decision. But we have benefits of 24-hour postural management and therapeutic positioning as well as that repositioning and turning. We have got to look at physical health, we've got to look at mental health, and we've got to look at social and well-being for them. Now, under those headings, there are an awful lot more divisions. And as you can see, I've divided them up to help you. First and foremost, of course, always at the top of people's list is the tissue viability aspect of it. And there are various reasons that we might want to reposition somebody. Reduced risk of developing pressure ulcers, it aids lymphedema management, maximizes healing process, optimizes skin integrity, reduces the risk of moisture lesions, and improves management of thermoregulation and the microclimate. But it's not just tissue viability that comes into play. We have to look at respiratory function. And of course, those of our patients who have got respiratory problems regarding COPD, lung cancer, etc., the position we put them in can actually have quite an effect on how they manage from hour to hour. Circulatory function comes into this as well as effective digestion and pain management. Pain management tends to get left out sometimes, but when we have got somebody with a neurological condition, certain positions can actually cause quite a lot of discomfort. We can decrease musculoskeletal and neurological pain by making sure that when we do reposition, we actually support limbs in the correct position. We maximize their comfort, we improve functional activities, and we also can decrease dependence on equipment, care, and provision. And perhaps sometimes we can reduce the need for pain medication. Talking about the range of movement and contractures, many of the people that I do see have contractures that unfortunately are already fixed at the time that I get to them. And that does, of course, create a challenge. It creates a challenge not just in the position we're going to put them in, but actually the type of equipment that we can use to prevent that getting worse, or if it's not fixed, actually improve that range of movement. That's really quite a big part of what we need to look at. And then we have body symmetry. That's also ensuring that whatever position that we put the person in, we're not going to affect the alignment of the spinal posture. We are going to manage the pelvis, because we do have to think about when we get the person out of bed and we sit them in a wheelchair or a chair, what we have managed to achieve or not achieve in the bed can affect the position in the chair. So this comes into play with whatever positioning that we are trying to manage. And then we have fatigue management, mental energy conservation, physical energy conservation, dignity, social and psychological well-being, a massive part. If we make our patients comfortable, and if we ensure that we give them the maximum amount of independence that they can manage in that position, if that's what's necessary, then we can actually help them in many different ways. We don't want people to be uncomfortable, and particularly at home when they are on their own for a long, long time, not managing in any way, shape or form. So to ensure that we do everything in the best possible way, when we leave that person, we are not going to cause any further damage or discomfort, has to be one of our priorities. Moving and handling, of course, is a big issue. Carers in particular, once we leave the person at home, they're either going to have a live-in carer or they're going to have once, twice, 3, 4 times a day visits from carers. We need to ensure that those carers are going to be able to move and handle that person in the best possible way. And what we don't want to do is put equipment in that actually makes it more difficult for them. So whatever we do, we're trying to make it in the most simplistic way, but still managing all of those issues that I have mentioned previously. Of course, some of the issues, again, that we have is we're seeing many people with dementia who have developed a specific way of lying in their bed, and they are very resistant when we try and improve that position. So that becomes a problem for the carers and when they are moving and handling. But of course, they also have to do pad changes, they have to wash people, they have to ensure that skin is left in the best possible way when they've gone, that they have washed and dried correctly. If they're unable to manage that person because of contractures and because of fixed contractures, that makes everything far more difficult for them. And of course, it also can increase the potential for that person developing either moisture lesions or pressure ulcers. So we're not just taking into account the person, we're taking into account those people who are going into care for that person in the bed. So what I'd like you to take away from this session is that it is all about individual risk assessment, and there is a massive amount to take into consideration when you make that decision. Now, sometimes the best that you come up with doesn't necessarily mean that it is best for the person, and this risk assessment is all about managing it for the best of everybody. And sometimes, certainly in the community, we have to reduce the risk as best as we can without causing other problems. And then also, we have to consider support surfaces, because the support surface could affect how that person is turned, how the carers manage the person, and how we manage positioning. There can be times where we're going to put in nighttime positioning, and that will mean that sometimes that person isn't able to be physically turned or using an automated piece of equipment to reposition them. So we have to think about that support surface very carefully. And there are two main principles. We have reactive, which is pressure redistribution, which is mainly static surfaces that aren't powered. And we have active, pressure relieving surfaces, which are alternating with cyclical inflation and deflation, which are always powered. So that's something else that has to come into play when you're making all those decisions. This is a 10-minute presentation on the vast subjects, as I've already said, and hopefully from some of those tips and some of the information I've given you, you can take it away and make informed decisions for your individual patients. Thank you.
Hi, well, thank you everybody. I'm just going to spend the next few minutes talking around the benefits of automated repositioning compared to the manual repositioning that we currently do. So what we currently do most of the time, and what we've traditionally done for a very long time, is we reposition our patients to an angle of 30 degrees, because obviously that's in line with all the evidence. And we do that by manually repositioning patients using pillows, wedges, cushions, that kind of thing. And that traditionally has always been done by clinical staff, often nurses, obviously not always, but often, carers, and also patients' own loved ones at home particularly, or even sometimes in the care setting. What you can see on the screen is a couple of pictures. If you look at the one in the top right, for those of you who have been nursing as long as I have, you may recognise this as what we used to do to reposition our patients, which was the Australian lift. And in the bottom you would see what we also used to do, which was a drag lift. We know both of these things are not good for either patients or carers or loved ones. And certainly the Australian lift has not been used for many, many years now. I apologise for the poor photograph, but sometimes you may see that loved ones might still do a bit of a drag lift, and we know this isn't very good, particularly for patients' heels and sacrums. More recently, what we do when we're repositioning our patients is that we are using devices to help us. So we're still manually repositioning, but with the assistance of things like hoists, slide sheets and wedges to keep those patients in the position that we're putting them, maybe pillows as well, as per this photograph. So that's what we currently do, and what is sort of considered the normal practice. But like so many things in medicine, things are evolving, and we now have another option, which is an automated repositioning device. So in the same way as we now use pumps to administer IV fluids, whereas back, as I say, when I trained a long time ago, it was all done manually, we can now automate repositioning for some of our patients. And we're going to look at why we need to, why we might automate that repositioning. And we're also going to look at those patients that we can't use it for, because that's really important. You'll notice on the next couple of slides, I'm going to go over automated repositioning. And then in the blue text, I've put those people that might be benefited by this. Now, there may be more than that. I may have forgotten some, or they may just be more people. So it's just to give you an overview. So if we're automating patients, we can guarantee that they are being repositioned to that recommended angle of 30 degrees because the lateral turning device is set for that. And the other thing it does is give that full top to toe repositioning. So they're getting repositioned in a straight alignment, because what we know is sometimes when we're using pillows, we're putting, because of how we position them in, sometimes the patient's body may be slightly twisted. And we know that that's not very good for them, and it's not always very comfortable. So if you're using an automated device, we know that it gives them that angle and also that full head to toe support. We also know that the manual repositioning, sometimes timings slip a little bit. All we need is something to happen, and that 2 hourly repositioning is suddenly 2.5 hours. So if you're using an automated device, then you can guarantee that the timings are as you would prescribe. So if you're asking for 2 hourly repositioning on both sides and maybe 30 minutes on somebody's back, you can guarantee that that's going to happen. Now, that obviously benefits the patient because it's good for their skin health, and it also benefits the clinicians because they're not having to clock watch or get in a, oh my goodness, I need to get to go and see Doris because it's time to reposition her, but actually I need to do something else as well. So it's guaranteeing that timing. Really importantly, we're finding that using automated repositioning devices are helping to support care packages in the community. Now, they don't take away care packages, they are part of a support for that care package. But we know that overnight care is not available in the vast majority of community homes. Obviously, in a nursing home, that's different. But we also know that staffing numbers overnight are often reduced in healthcare facilities. So what it can do is support patients to go home, be looked after in their own homes, whereas previously they might have needed to go into 24-hour care because they need that repositioning overnight. So this obviously benefits the patient because they want to be in their own home, the vast majority, their family members because equally they would rather have their loved ones at home, carers because we don't have those carers overnight, and also the healthcare system because it releases some healthcare for other provision. So it supports that package of care. We also know that being automated repositioning can reduce sleep disturbance. I'm sure everybody on the call or on the webinar knows what it's like to have a disturbed night. You're unwell, you've got young children, maybe you've got a puppy or something, and your sleep is disturbed, and we all know how that makes us feel. Well, the same applies for our patients. If you're automated repositioning, you're not getting disturbed by people coming in and having to maneuver you around so much, or the noise that goes with that. So sleep disturbance, it can help with that as well. We know that automated repositioning devices help those patients who experience pain when they are being repositioned. And we also know that some people are having to have analgesia before they're being manually repositioned. If you're using an automated device, then it can reduce that need, and it definitely can help with those patients not having to experience so much pain when they're being repositioned. Obviously, this benefits the patient, benefits their loved ones, because actually it's not very nice knowing that your loved one, the patient, is in pain when they're being repositioned. Benefits carers and clinicians, because none of us like moving somebody when they're finding it uncomfortable. We do it because we know we have to, but it's not always very nice for those giving the care either. So just continuing on, we know that some patients find being repositioned distressing. Now that may be because of pain, but it may be for other reasons, cognitive impairment or something. And again, if you're using an automated system, that can reduce the level of distress because it's very slow and very gentle for them to be repositioned. They're not having to have so much of an intervention. And again, that will benefit the patient, their loved ones, carers and clinicians for similar reasons for those suffering with pain. One thing we've had reported back from clinicians is that they feel that automated repositioning helps preserve patients' dignity, because again, when we're using things like a slide sheet and pillows and moving patients manually, some patients find that very undignified. So we have had reports that the dignity is improved with using an automated system. We know that sometimes patients' skin, particularly as they age, their skin gets thinner and it gets more delicate, and therefore it's more prone to skin damage, bruising, skin tears. So when we're manually repositioning, there is a little risk that that may happen. Using an automated system can reduce that risk because we're not having to be having in our hands or whatever stressing the skin. So that's the benefit to the patient, obviously the carers and the clinicians. If somebody gets a skin tear, then obviously it can take a very long time to heal, particularly depending on their comorbidities and with increasing age as well. Certainly, automated repositioning is used a lot with end-of-life care. It frees up time for loved ones to be with their family members. It also means that the patients are still being repositioned at end of life for their skin health, but without that disturbance to them. So that benefits the loved ones. They can spend more time with their family member, and it benefits the patients because it's less distressing. We know that end-of-life care is quite a difficult time because we're often asked not to reposition our patients, but we also want to continue giving that level of care. And those are some difficult conversations we need to have sometimes. With the automated system, that negates the need for that conversation. And then benefit for the carers and clinicians is it's less risk on you. Musculoskeletal damage is reduced. Repeated repositioning of patients, obviously it can take its toll on us. And although we have many more things in place now, as we looked at with hoists and slide sheets compared to what we did decades ago, we still know that people do experience musculoskeletal damage, and it can put them out of work and all the impact that then has on them. And finally, it frees up time for the clinician and the carer for other interventions. So that may be talking to your patient, helping them eat properly, giving them medication, sorting out their discharge if they're in an inpatient setting, whatever else you need to do, it frees up some of that time. So there are many advantages to using an automated system for repositioning. As I mentioned at the beginning though, we need to consider that some people are not suitable for this. And for us, with our system, we will say that patients with an unstable spinal fracture are clearly not suitable for an automated repositioning device. So if there is any consideration around that, you need to have it documented by a medic that any fracture or potential fracture is stable. So unstable spinal fracture is a contraindication, as is the patient on traction. Now, we don't use traction much these days, and we certainly don't use it in the community. But if there is any use, then it can't be used with a TOTO. Patients suffering with equilibrium disturbance, so that's like a balance issue. So the classic would be a vertigo. Again, it's contraindicated for them because it may set off an episode of vertigo or whatever their condition happens to be. So that tends to be contraindicated for the use of an automated lateral turning device. And then obviously if the patient is over the weight limit. So the weight limit of TOTO and TOTO cradle is 250 kilograms. If you consider that the working weight limit of most community or hospital beds is around the 180, 190 kgs, then you'll be fine. But the weight limit of the TOTO is 250. I've put in there, it's not a contraindication, but I've actually put down young paediatrics will not get any benefit from using the TOTO. So the youngest I've been asked for is like an 18-month-old baby. Well, clearly they're too small to benefit from the angle of tilt that the TOTO can give. Obviously, if they get older and bigger, then yes, you could use it for paediatrics, but you need to consider the size of them. So those are the contraindications around who can't use an automated system. Then in addition to that, there's sort of like considerations to think about. So those would be patients who are have some dementia or a cognitive impairment. Now we know that lateral turning systems are used with these patients and used extremely effectively. But what we tend to say is maybe for the first time you're using them with this patient group, just tilt the patient from side to side and see how they react, and check that it's not making them distressed. I haven't had it probably once in 6 years, but obviously I don't hear about everybody. The other patient considerations would be those with severely contracted limbs. So if somebody is contracted to within the fetal position, so their knees are belled up, so maybe their feet are up on their buttocks or something like that, they're not going to get any benefit from that tilt function. Now, if somebody has some slight contractures or maybe one side, and you can manage it with things like pillows, T-rolls, positioning devices, then you can probably use the Toto. But if they're severely contracted, it's not really going to give them the benefit to offload off of that bony prominence that you're looking for. If you've got patients who are likely to slide towards the edge of the bed and can't reposition themselves back up, then again you need to consider how that's going to be for them. There are ways around this, and certainly one question we get asked around a lot is sleep systems. So you can use Toto with a sleep system. You just need to make sure that that sleep system, when the patient's at tilt, isn't exerting any additional pressures on areas of the skin. And obviously, if you've then got patients who you feel are likely to be climbing out of the bed, you need to do your risk assessment for whether that's going to happen or not. And on the suitability checklist, you can see on the slide in front of you, you'll see at the bottom there's a little bit around bed rails, and it gives you the measurements that we would be looking for to make sure there's no risk of entrapment. And those are just in line with the MHRA guidelines, but you need to be doing your bed rail assessment as you would with any piece of equipment, any mattress or everything going in, if you're using bed rails with the Toto. And that's the consideration, whether you need them or whether you don't. So those are patients that you can't use it on, and maybe the watch outs, the considerations. So just to finish and to summarise, and this was quite difficult really, in summary, automated lateral turning systems can enhance the care provided to our patients whilst freeing up time for carers and clinicians for other interventions and reducing the musculoskeletal impact on them. So hopefully that gives you a brief overview of why we might consider automated repositioning. Now it's available to us. And any questions I'll take at the end of this session. Thank you very much.
Hi, my name's Simon Bosley. I'm the Technical Director at Frontier Medical Group, and I've got the pleasure to spend the next few minutes to talk to you around the Toto patient lateral turning system and the new product launch of the product upgrade of the Toto Cradle. Toto Cradle is a automatic patient lateral turning system, which is designed to automatically redistribute patients' pressures and reduce patient peak pressures, whilst enhances using well-being and supporting improved patient clinical outcomes. The new cradle is really designed to offer enhanced comfort, support, and also increased compliance when dealing with all different patient types. Toto is a medical device which is designed to assist healthcare professionals in turning and repositioning immobile, less mobile, and bedridden patients. And as we've previously heard, repositioning is essential to prevent pressure ulcers, improve patient comfort, and also to reduce the risk of complications associated with immobility. And that's both for patients and also healthcare professionals. Toto was first launched in 2017 and has been successfully used internationally in all healthcare environments, including home care settings and hospital environments as well. Based upon user feedback and also through clinical trials and evaluations, users observe and appreciate and benefit from pressure ulcer prevention, respiratory comfort, and healthcare provider efficiency improvements, and has been found to be particularly useful as an adjunctive therapy in resource-scarce environments. The system provides 24-hour care in a controlled way and provides full body turning and rotation in a lightweight, easy-to-use single-person system. And And the way that it works is that it's placed directly underneath the user's mattress, and air cells are inflated alternatively in an even, smooth and consistent manner, 24 hours a day, even whilst the patient may be sleeping. The control unit can be customized with user-determined timings, or can be the default settings can be used. The platform itself is completely adaptive to most bed frames, meaning that whilst the bed frame is articulated or profiled, and even in rise and recline positions, that the system will work effectively, and can be used and is suitable for use with high specification foams or dynamic and active mattress systems. It's multi-patient use, and the full system can be disassembled for cleaning and care, and the cover is resistant to fluid, and is also providing a bacterial barrier as well to the system. Building on the success of the Toto system, the new cradle feature is being launched for 2023, which is a dual cradle support system, meaning that whilst one side inflates, the alternative slide has a slight inflation to increase patients' feeling sense of security, and also remove or reduce the risk of any unwanted patient migration across the surface, whilst at the same time providing effective pressure redistribution. In addition to pressure ulcer prevention, Toto offers additional benefits, and that is that it can reduce the risk of caregiver musculoskeletal injuries and avoided staff absence as a result. It can also reduce the risk of any unwanted patient damage through skin tears and bruising, through manual handling activities that take place, the manual turning. And it also ensures that there's correct positioning take place, reducing the need for additional wedges and body supports, whilst also preserving patient dignity and managing patient governance from a documentation side perspective. So as a quick summary, Toto can be seen to be clinically effective at repositioning by providing consistent and controlled turning. It promotes patient safety and improves healthcare provider safety, improves patient concordance and compliance. It conforms to most bed systems which will be in use, is easy and quick to install, and provides effective turning. Frontier offers multiple avenues for training and support, and that can be done either in person and via video sessions. And for more information, please don't hesitate to contact Frontier Medical with the information that's on screen now. I'll be around. Thank you very much. I'm around for questions, should you have any.
Thank you, Francis, Lisa and Simon. Really informative presentations, and thank you to everybody who's watching. We've had lots of questions come in. I think there are a few that I can maybe also with the dementia patients. Is it the movement that you're concerned about? Does it frighten them, or is it that you're worried that they might try and escape?
So we lost you a little bit there, Jackie, but I think you might. So you were asking about dementia patients, whether the movement would frighten them?
Yes.
Maybe. So our experiences and what we tend to recommend with Toto, if you've got a patient with dementia, that probably the best thing to do is just stay with them the first time that you move them from side to side, and you can override that, so you don't have to do it for the whole 2-hour repositioning time. So, but we know that patients with dementia do quite well on the Toto. So, but it's just that you need to make that assessment as to if it is going to frighten them or anything. But certainly, in my experience, generally it doesn't. I
think the second part of the question, maybe where you lost me, was there's a question about the issue for the patients who move towards the edge of the bed? And I thought that might be similar to the patients with dementia where they're edging out.
Yeah, so if we've got patients that you're worried about moving towards the edge of the bed, ideally we want them in the centre of the bed so they get the benefit of the 30-degree tilt. So really we want them to be able to sort of position themselves so that they are centrally. So again, I think it's down to that assessment that when they're at tilt, when they're tilted, are they going to be moving significantly? There are ways around that we can support with maybe pillows or something just to make them feel safe and secure, but without shoving them underneath them. But there's certainly things that we can do to support that type of patient. And with regard to the cradle Toto, then it's absolutely designed to make sure that travel towards the edge of the bed is reduced significantly. So that's the whole point of the cradles. It's designed to stop that system with that system.
Thanks, Lisa. Simon, a quick question, I think, for you. In terms of you talked about being able to set this to suit the patient. Can you set it at different frequencies for day and night, or do you have to manually do that? Change the frequency at night time?
Yeah, thanks, Jackie. Good question. The system, once you've set the timers, that will run 24 hours a day until either you turn the unit off. So if you did want to have different settings during the day and during the night, you would need at the moment to go back and make that manual change on the control unit.
Thank you. And I think all three of you talked about the significant benefits of this repositioning, things like reduced sleep disturbance, pain, skin tears, staph back injuries. What's the evidence to support all of those? Frances, I think you talked about a group you were involved in.
Yes, we wrote a guidance for the National Association of Equipment Providers some years ago, and it was the group were clinicians who were very much involved in their own areas in postural needs, seating and nighttime positioning. So we did a lot of research. I can look some of that up because it's in the document. The end of the document actually has all of that, but it was guidance on therapeutic lying. That could be made available if people would like to see it, because there's quite a lot of detail in that. Yes, there's some evidence. I would have to come back to you to provide that.
Thanks, Frances. And from the Frontier team, is there anything else you would suggest if people wanted that evidence anywhere else they should go to? Is it something you provide?
I think from our perspective at the moment, a lot of the stuff around like skin tears, reducing reducing bruising, that kind of thing is what we're getting told back anecdotally, but obviously we are always looking and doing more and more studies as well. And we are certainly looking largely around how we're using Toto, not just for skin management, but also for other therapeutic areas. We've certainly got a paper for respiratory.
And there was a question about, I think it was in your presentation, Simon, you said something about it could be used on different bed frames and rise and recline. Does that mean you can use it in the riser recliner chairs, the kind of tilting space chairs?
It's a really interesting question, Jackie. I think when we developed the product, we considered different care environments and also the different suppliers of bed frames and equipment that are housed in all areas of the NHS. I'm sure you'll be able to tell me more than I that the different ages of products and devices that you currently have access to within healthcare establishments. So we tried to find something that could be used in the vast majority of cases, everything from fixed bed frames to multi-section and profiling bed frames. So if you look at the device design, it's really it will articulate in any given situation. Certainly whether you just got the headrest elevated or the knee brake elevated, the system will work really well with them in any of those orientations. With regards to riser recliner chairs, Jackie, if that's your question, in the home environment, the product hasn't been evaluated in that instance. So I would say that it's only really been looking at for mattresses, because remember, you need to put a mattress on top of Toto. You can't sit or lie directly on top of Toto. So it's really to go under, it's not a mattress replacement system. It's designed to go under a static or an alternating system. So that's important to point that out.
And that's a really important point to make, isn't it? This isn't instead of a mattress, it's alongside a mattress.
Yeah.
Lisa, if I can ask you, you talked a lot about the benefits, and there's a question coming in about a potential contraindication or a downside, so that if we're not engaging in doing the manual repositioning, what does that mean in terms of the things you'd normally do when you reposition? So you'd be doing maybe a skin inspection, checking for pressure damage, or you'd be checking if the patient was incontinent. Does that mean that those don't happen?
We would say that you still need to do your skin inspections. You still need to check for incontinence, of course. What it means is that if you use an automated system, it frees up some time to maybe do those interventions and other interventions. So I suppose one would be, if somebody is incontinent, maybe it gives you a bit of time to investigate why they're incontinent. I suppose the classic would be, have they got a UTI, if this is a new episode of incontinence. The other thing from my perspective is that it means that you're not so time bound. So traditionally we manually reposition and say 2 hourly. And we all know that in practice, that's really difficult to achieve because things happen. Somebody falls in the bathroom or something happens at home. And so what it means is you'll still do your skin checks, but you're not so time bound by things. And also you're freeing up that time for other, even, talking to your patient, helping them eat, that kind of thing as well.
Thanks. And I think this is probably a question for you, Simon, just come through. How would the height of the Toto with the mattress on top affect the height of the bed rails and the regulations around this?
Yeah, this is really important, and it's one thing that we've really taken seriously during the development and through the risk assessment process. So there are 2 key standards which are available, which are published. They're international standards which looks at bedside rail manufacturing, and then also there's one for young people or smaller frames. There's 2 different standards there. Now, both of those standards were considered during the device development. And off the back of that, in our instructions and training material that all Frontier people will do with you, is go through that process of understanding the gaps, both horizontal and vertical gaps that exist when using Toto and a mattress system with the bed rail that you've got in place. At no point does it take away from the need to do a risk assessment. So we strongly recommend that, whenever bed rails are being used, that risk assessments take place. Through our investigations and with when we've looked at different combinations of devices, Toto in all of those instances would maintain the gaps that the standards would recommend. So it doesn't introduce any additional risks, that's important to say, but again, it doesn't negate the need for clinicians to do risk assessments when using bed rails and those equipment combinations, period, of any pressure relieving equipment, not just Toto.
Can I just interject there?
Yes, sure, Francis.
The MHRA have just recently relaunched their amended bed rail guidance. It's not long come out, so that should be available for everybody, either online or within your organisations. That should have been sent out to everybody, and that has got all of the gaps that there should be for beds for children and for adults, etc., and a tick checklist as well.
It's always helpful, isn't it, to have a checklist to work through things. And Francis, a question for you. I think you've got quite a lot of experience in using these. There's a question about motion sickness, and I think there was mention of being careful in patients who have equilibrium disturbance, and that I suppose that's where that comes from. So we used to get lots of problems with the old alternating mattresses, where the head went down. Have you seen any problems with this changing the patient's position? Do they feel seasick? Anybody? I haven't. Identified?
No, I actually haven't. And bearing in mind, once that equipment goes out, unless there is a big problem, I'm not going to find out that there is, because it's based on the district nurses mainly putting that out, and they would come back to me if they found that there was a problem, or the care agencies would report in. And as I have not in our area had any problems with that at all. Having said that, obviously, that becomes part of your risk assessment, doesn't it? So that when you're looking at shall we, shan't we use it, you're looking at the diagnosis of the person as well, and that should kind of flag up that there could be a problem, and it's something that needs to be watched as well.
Thank you.
Only to add in there, Jackie, that through post-market surveillance activities as well, we don't hear of those issues arising.
Okay, thanks, Simon. Lisa, because you talked about continence, I'm going to come back to you with the question about the Foley catheter. Anything specific to think about? I guess they're thinking about either entrapment of the catheter or tension on the catheter and potential to cause like urethral pressure damage.
Exactly, 100%. Yeah, we definitely don't want the catheters being pulled out or being pulled and causing more damage as a medical device pressure ulcer. So what we tend to say is obviously make sure that you've got enough tubing of the catheter. The catheter is long enough and into a leg bag and then onto a night bag, so that when the toto is tilted, that there's no additional pressure. The other way we know sometimes, but it will depend on what catheter you've got, and I'm no continence nurse, I will say this now, we will say lie it down the centre of the bed, so that when the patient is tilted from side to side, that it's not getting any of that additional tension. But like I say, you need to look at what your bags you're using and the actual catheter for that as well.
Yeah, that might affect the drainage a little bit, might it, depending on the patient.
Exactly. And also if you've got the knee brace up, obviously there's drainage. I know they're non-return valves now, but even so, I think that's something you need to take into consideration. So it's the length you need to look at.
And Simon's question about the operating system, can it be battery operated or just electrical, or can you do both? And if it's battery, what's the battery life?
Nice easy one. It's mains powered.
Okay, and there's another question, I think, which is probably for you, because it's talking about head of bed elevations, because it's lateral repositioning. If you've got somebody with respiratory problems, obviously you want them with a high head of bed elevation. What's the maximum head of bed elevation you could use this at?
In terms of looking at the design, it'll conform to any elevation that you want that it needs to be, and it'll enable turning to continue to take place during that time. So Lisa, there's no maximum that we've seen here on this, right? So, you know, standard 30 or 45 degrees is perfectly okay.
Yeah, so what we tend to, when we're out and about, what we get told is anything at more than about 45 is just uncomfortable. Yeah. And also that your risk is, or your concern is, that they're going to tilt. So we try, and obviously with tissue viability and pressure ulcers, ideally we don't want them at a high angle, we want them at a lower angle. So 30 to 45 degrees, we tend to say head of the bed elevation is the most comfortable. After that, it just gets that they don't tolerate it so well. I think one thing that's really important to note is that you still probably using the knee brace really helps with the comfort. So and obviously we would do that anyway to stop those shearing forces going down. So I would suggest you still need to use your knee brace for the vast majority of patients, just from a comfort perspective, let alone all the benefits that brings with you.
Thanks, Lisa. A couple of finance questions. So one was, is there any health economic data? And there's a second question, which is it possible to hire the equipment if buying is cost prohibitive? Do
you want me to pick those up a bit? I can pick up some of that. Okay. Yes, there is a rental model. So yeah, absolutely, there is a rental model in the UK. If you're listening in other countries, I can't answer for those, but currently in the UK there's a rental model. And what was the second part of that question? Oh, health economic data. We have a case study where somebody independently had done their data around how much, with a particular case study, that they had reduced spend, and that was looking at district nurse time, it's looking at dressings, it was looking care provision around those things. So there is that, and it is also something that we were looking to explore further too. I think that's a conversation Simon and I will be having. But Simon, I don't know if you've got anything to add to that.
No, other than there's a few studies in the pipeline that are about to kick off, which will answer or reinforce some more of these questions as well. So keep an eye out for the future.
And I think there's just one more question, which is about using satin sheets with toto. So I'm guessing these are like the anti-friction sheets. Lisa, would you recommend that use, or does that make the patient slide around a little bit too much?
So if you're using satin sheets, no. If you've gone to John Lewis and bought some satin sheets, you're probably going to slide towards the edge of the bed. If we're using something like a Wendy-Let or similar, sorry to use those names, but that's the one I know, you need to be able to lock them off. So you need to make sure that they are locked off properly and that any carers using them know how to do that properly as well. Frances, I don't know if there's anything from your experience that
Yes, so we have actually said when we're using the Toto that the general rule of thumb is that we would advise that people put bed rails on, because in the person's own home so often they are left overnight on that system and there's nobody checking on them, and even if there's a living carer or a family there, there's a long period of time sometimes when the person's on their own. So we have to cover all bases in the community. We do use satin slide sheets, and that is the name of the sheets that we use. One of the issues that I have is time and time again I go in and actually find satin slide sheets incorrectly put on the bed, or they are not locked off. I go over it with the carers every time, and I usually get hold of that care agency and the company that we use and ask them to liaise together to do training with all the carers on the satin slide sheets. We're just finding all the time they're not locked off, and they all tell me that they've had the training, which I find rather disturbing. So again, it comes down to our individual risk assessment. Are we going to use satin slide sheets with this particular patient or not?
Thanks, Frances. I think, Simon, I've got a little slew of questions for you because they're about product development, or actually about the product. So the first one I think is a quick one. How long will the Toto stay inflated if it's accidentally switched off or unplugged?
So there is a CPR function in there, which will dump the air in, I believe it's less than a minute, in case of emergencies. If the natural deflation time of around is nice and slow and steady, the last thing that we want to do in non-emergency environments is for patients to sort of land down on their back. So that deflates over around about a 3 to 4 minute period. So it's nice and slow and nice and steady in that instance.
And presumably there's an alarm to tell you that it is not functioning. Yeah,
100%. So there are several different alarms which are on there. Air leak, whether or low pressure alarm, whether there's a blockage, that there's sort of product malfunction or software failure, and also accidental disconnection of the power lead as well. So there's the alarms on there are fairly comprehensive.
And then there's a question about digital technology and what's the potential for this. So the question is about actually for the patients being able to use this without their arm function to operate it. But I would also say, what are your thoughts about linking this so that a remote clinician could be looking to check that it's still working or be getting some feedback?
I think there's a few things on this with regards to sort of new product development and future innovations. There's lots of change going on within the NHS, and I think, and globally, especially with the advent of things like virtual wards, and having patients being treated and cared for at home. So remote monitoring is clearly on our agenda of things to investigate. One thing that I would add is that we've recently opened a new innovation centre, and where we're looking at all future market trends within pressure area care, and looking to develop new technologies to best suit and hit those needs. And we're looking for people to be involved in that. So those of you with tons of experience who want to provide some feedback and get involved in new ideas and new innovations, come and contact us. We can have a coffee and talk about some ideas that you may have and areas where you think we could do better.
Fabulous, thank you. And then there's just one last question. It's about, is there any additional benefits if you're using a Toto to use it with an alternating pressure mattress?
The evidence that we've got is it all comes down to what surface you're using, right? So again, just to repeat, this doesn't take away from the pressure redistribution surface that you're using, whether it's a static foam or an alternating air. The data that we've generated both in-house and also out-house, there's not a huge amount of variance in between the different types of alternating mattresses that you use. Again, it's such a big holistic question when we're looking at risk assessment and looking at the patient demographics and the patient sort of height and weight, etc., etc. So it's a really difficult question to answer. That being said, If you're using hybrid surfaces or you're using alternating air mattress surfaces, what we see is things such as devices with high levels of immersion and envelopment, like Repose mattress overlays, give better results than firmer surfaces.
Thanks, Simon. So thank you to all our three speakers. I think that's been both really informative videos and actually a really good question and answer time. A couple of questions that are just not appropriate to ask the speakers that you've been asking from the admin team. Yes, your certificates will be available and you will be able to watch the video on demand. So can I thank our three speakers for what's been a really excellent session. Thank you for attending. We hope you've enjoyed it and we look forward to seeing you soon. Thank you. Goodbye.